Good evening, one and all, and welcome to Med School Grammar. It is my pleasure to introduce our guest today, Dr. Rohan Khandelwal sir, who is a passionate surgery teacher, a breast cancer surgeon. I'll just add Rohan Khandelwal sir to the live session.
Good evening, sir.
Hi, good evening. Are you able to hear me?
Yes, sir.
Okay,
Sir, am
perfect.
I clear? Am I audible?
You're audible. You're audible.
How are you, sir? I hope you're doing well, sir.
I'm doing good. I'm doing good. What about you? Keeping
Yes,
safe,
sir.
I hope all of you are
Yes, sir.
keeping safe.
Thankfully.
Yeah,
Yes, sir.
tough times for everyone.
Yes, sir.
Hi, everyone. Hi.
Good evening, one and all. Today we have with us Dr. Rohan Khandelwal, who holds the degree of MS, MRCS, and FIBD. He is the director at Department of Breast Surgery at CK Birla Hospital, Gurgaon. He has been a surgery faculty since the last 11 years, which speaks a lot about sir's experience, and he is currently associated with Marrow. Welcome, sir, to our channel, and it's an honor to have you, sir.
Thank you. Thank you very much. Hi, everyone. I hope all of you are keeping safe. These are tough times for everyone. And, somebody in the family or close circle, everyone is suffering from COVID. We're losing people left, right, and center. So really difficult
Yes,
times for everyone.
yes, indeed, sir.
Just take all the precautions. Some of you might be frontline workers who must be attending to COVID patients. So don't neglect the PP guidelines, even though I know they're very difficult to wear for long periods of time. I wear them when I'm operating, but they're your only line of defense. So just take all the precaution you can. And yeah.
Okay. So in today's session, sir would be discussing an important abdominal emergency that is frequently encountered not only in practice, but also in the exams. And this would be followed by a doubt clearing session where sir would take questions. So please stay till the end and you can put up your questions and sir would answer them.
Sure. So
So
I'm doing absolutely fine. I'm fine. I might be looking a bit tired or because it's been a long day. I had a busy day at the hospital, and then Rohani keeps me on my toes as well. So
yes,
otherwise,
sir.
everything is fine. Perfect. Yes. I love this page and I follow med school grammar. And actually, I had asked them that if I could post a case there. So, they then we decided to have an interactive session where we can discuss a case. And after that, I'll be happy to answer any queries which you have regarding anything. 10, 15 minutes we'll keep for that. But let's start with something academic. I think so. It'll be a good thing to break the monotony and only looking at
Yes, sir.
COVID related posts the entire day. So
Right.
okay, so my patient, this is an actual case, a person known to me, a 45-year-old lady.
Okay.
She has no comorbidities, but
Okay.
4 weeks back she came to the emergency with a right upper quadrant pain since the last 2 days, and she was also having nausea and vomiting.
Okay.
Um, when we took a history from her, she said that she had a similar case, a similar episode a couple of months back, but she took some painkillers at home and she was fine in a day's time, right?
Okay, sir. Right.
She's been complaining of some amount of dyspepsia as well. But
Okay.
since the last 2 days, the pain is really bad. On a score of from 1 to 10, it is a 7 out of 10, not getting relief by the regular painkillers.
Okay, sir.
Okay. So that's the patient who's come to you in
Yes,
the
sir.
emergency. And what would be your first thoughts without even sharing the examination? Everyone who's listening to us, what do you think is probably the case which we are discussing?
Sir, so according to me, she is a female in her 40s. So
Hmm.
she is, and she has right hypochondral pain. So she might be suffering from gallstones presenting as acute cholecystitis as emergency.
Okay. All right. So I think so that's what most of the users think as well. So they're thinking on the lines of cholecystitis. Some people are saying pancreatitis could be there, could be pancreatitis as well. So fine. We did an examination for her, and on examination, she had extreme tenderness in the right hypochondral region. No mass was felt, just pain in the right hypochondrium, and no other abdominal signs. The bowel
Okay.
sounds were present as well.
Right.
No jaundice. Now, what
Right.
do you
Okay.
think? Do you think this cements your diagnosis of cholecystitis?
Yes, I still think it is cholecystitis, but we would need certain investigations to confirm our diagnosis.
Okay.
And I would like to do an ultrasound in
So,
this
I
case.
mean, let's talk about the clinical examination. But some
Yes, sir.
people mentioned Murphy's sign. What do you
Yes,
mean?
sir.
What is Murphy's sign?
So Murphy's sign is on palpation of the right mitochondrium. The patient winces in pain, and there is a mid-inspiratory arrest. That is the
Correct.
Murphy sign.
So the patient catches his or her breath, and
Yes, sir.
that is the correct thing. It's not just tenderness. So that is something
Yes,
which
sir.
people should be aware of. Okay, so right. So I'm thinking on the lines of cholecystitis. What would be the investigation which you would like to do when such a patient comes to the emergency?
So I would like to do an ultrasound in this case to
Okay,
confirm my diagnosis of cholecystitis.
right.
And so,
What kind of findings would you see in an ultrasound?
this is a patient who has had a history of similar episodes in the past.
Mhm.
So I would think on lines of acute on chronic cholecystitis.
Okay,
And on ultrasound, it would show a wall echo shadow sign
all
with
right.
a thickened gallbladder wall, gallbladder stones, and a posterior acoustic shadowing.
All right. Sounds good. So everyone who's listening to us, do you agree with the description which has been given? I think so. People agree with you. So I also agree with
Yes.
you 100%. We'll do
Yes.
an ultrasound and you will probably see the wall echo shadow sign and you will see post-acoustic shadowing which you see in gallstones. Would
Yes,
you
sir.
see post-acoustic shadowing if it was a gallbladder polyp as well?
No, sir. In polyp, there is no post-acoustic shadowing.
Right. I have two polyps, and every 3 months I get myself checked up on a scan. So polyps don't show post-acoustic shadowing, but stones will show post-acoustic shadowing, as you've rightly said. Okay.
Yes.
Now, is there any other thing which you would like to do? So this patient has come to the emergency. What would be your initial management for her?
So initially, I would keep the patient nil per oral. I would
Hmm.
start IV fluids, IV antibiotics, and painkillers for pain management.
Okay. Tell me more about the antibiotics which you would like to start for this patient.
So I would like to cover the gram negatives as well as the anaerobic bacteria. So I would give a broad spectrum antibiotic to this patient.
Okay, perfect. Right. So I agree with that. And you'll give painkillers also in this patient. Will you send out certain blood tests for this patient?
Yes, we would like to do the baseline investigations like complete blood count
Hmm.
to look for leukocytosis. We would also do the liver function tests.
Hmm.
And sir, other investigations probably for anesthesia fitness we would like to do.
Okay, so one thing which I want to just clarify here, a lot of students are writing meropenem. No, you won't start this patient on meropenem. Meropenem, I mean, is an overkill for such a patient. So you will start the patient on something like monosep or second generation or third generation cephalosporin, and you will start the patient on metronidazole, which you rightly said, to cover the anaerobes as well.
Yes.
Then you said you'll send certain blood tests. You'll send a complete blood count, which is absolutely correct. And anything else which you said?
So LFT and for anesthesia fitness are the tests.
Liver function test.
Yes,
Okay,
sir.
liver function test, and you'll get an anesthesia fitness done. Okay,
Yes, sir.
so why are you getting an anesthesia fitness done?
So because if the patient needs to be operated in the emergency after we have arrived at the decision of operating the patient,
Hmm.
or if there is some other diagnosis and we have to delay, So in the meanwhile, the results can come and we can decide accordingly if the patient fits for surgery at this moment or no.
Okay. Some of the users who are listening to us are saying, will you send out an amylase and lipase as well?
Amylase and lipase, so in this case, pancreatitis is less likely, but yes, I would rule out pancreatitis by sending amylase and
Why do
lipase.
you think it's less likely? Can't a patient with the gallstones have pancreatitis as well?
Yes, a patient can present with pancreat. The differential diagnosis does include pancreatitis.
Mm-hmm.
Yes, so I would like to rule out pancreatitis with amylase and lipase.
Okay, all right. Now, you send the blood work, and the blood work comes back after a couple of hours. So, as expected, the total leukocyte count is 13,000.
Okay.
So, is it something surprising for you, or you were expecting that?
So we were expecting that, so leukocytosis may
Sure.
be seen in the case of cholecystitis.
Right, correct. So, fine. The amylase and lipase, we had sent it out, comes out to be normal. But this patient has a normal serum bilirubin, but the alkaline phosphatase is raised.
Okay.
And also, when you talk to the radiologist says that the CBD was 10 millimeters in diameter.
Right. So
Okay.
the C. Yes, sir.
So, my question now, you have ALP, which is raised,
Yes, sir.
and now you have a CBD,
Yes,
which
sir.
is 10 millimeters in diameter.
Yes, sir.
Now, how do you go about managing the patient? Do you still take up the patient for an emergency surgery?
No, sir. If the CBD is dilated and the alkaline phosphatase levels are raised, then my suspicion would go towards choledocholithiasis or CBD stones. So I would like to
But
rule
no
out CBD
CBD stone
stones.
was seen on ultrasound.
So I would still confirm it with an MRCP because MRCP is a confirmatory test. And after that, I would decide if CBD stones are seen, then the line of management would shift towards
No,
ER.
but I think so. You're jumping the point. What I'm trying to say is no CBD stones were seen.
Yes,
So,
sir.
what are the points which will make you do an MRCP? And what is the full form of MRCP?
So MRCP stands for magnetic resonance cholangiopancreatography.
Okay.
And sir, we would like to take the history of jaundice, and on USG, if there is CBD dilatation, then
Mm-hmm.
we would think in terms of CBD stones.
Correct.
And so the patient's bilirubin is normal. So, um, so,
So,
so
3 points to
yes, sir.
simplify. You rightly said history of jaundice,
Yes,
which
sir.
is not there,
Yes,
but
sir.
a dilated CBD, which was there on the ultrasound, and the third one was raised ALP.
Yes, yes. Okay.
Right, so these are the three things which will point that there can be a stone in the CBD, which might not be visible on an ultrasound. Ultrasound is not the best modality to look for CBD stones, especially if they're in the lower half,
Yes, sir.
right? So you will do an MRCP, correct?
Yes, sir.
Why not straight away an ERCP?
So because MRCP is a non-invasive technique, so we would not subject the
Fair enough.
patient directly to an invasive technique.
Fair enough. So you do an MRCP, and on magnetic resonance cholangiopancreatography, in this patient, you find that there is a shadow which you can see in the lower half of the CBD, which appears to be a stone.
Yes, sir.
Okay. Now what will you do? So we some students are asking why MRCP. So MRCP is non-invasive. So first, to see whether there is a stone in the CBD or not, you will do an MRCP. And if there is a stone, now what will you do?
So now we would do an ERCP followed by a sphincterotomy at laminal lock position. We will extract the stones.
Let's go step by step.
Yes, sir.
Let's
We
not.
do us in.
You'll do an ERCP.
Yes, sir.
Okay.
ERCP.
What is an ERCP?
So ERCP is when we use a duodenoscope, a lateral viewing duodenoscope, and we go till the duodenum and we reach the second part of the duodenum from where we inject the dye, and we can visualize the biliary tree. It is
Okay.
endoscopic retrograde cholangiopancreatography.
Perfect. Fine. So you do an ERCP, you find that there is a stone, you do a sphincterotomy, you remove the sludge, the stone which was there. Okay, that has
Yes, sir.
been removed. Okay.
Yes, sir.
Some gastroenterologists, when they're doing this, they also put in a plastic stent, right? So
Yes,
this
sir.
is something which I want you to know. Some of them put in a plastic stent which can be removed later on, and they put in a stent so that if there are any further stones, they can come down easily.
Yes.
So fine. Could you have taken up this patient directly for a cholecystectomy and dealt with the CBD stone during surgery itself?
Yes, we could have dealt with the CBD stones during surgeries. Sometimes the CBD stones are missed, but we do not prefer that approach. We do not go for cholecystectomy if CBD stones are there.
Correct. So if you know beforehand that there is a CBD stone, you won't want to take up the patient for surgery. You get an ERCP and then you take up the patient once the CBD has been cleared. Then you take up the patient for a cholecystectomy later on. Okay.
Yes, sir.
A lot of you are talking about T tubes. We'll come to T tube where the role of a T tube is there. I will talk about that. But ERCP, while doing ERCP, we are not putting in a T tube. We put in a stent, a plastic stent can be put in the CBD, not a T tube. Okay. Right. So you've done an ERCP, the stone has been removed. Now the surgeon decides, okay, after a few days, we'll take up the patient for a cholecystectomy, right?
Yes, sir.
Would you like to do a lap cholecystectomy or open cholecystectomy?
So we would go for laparoscopic cholecystectomy.
Okay, right.
Yes, sir.
Okay, you've done a laparoscopic. So a plastic stent is put in because a plastic stent can be easily removed. You don't put in metallic stents are usually inserted if there's a malignancy. So it's only a plastic stent which we put in. No, we won't do open cholecystectomy. He's absolutely right. We will do a lap cholecystectomy. Why do you want to do an open cholecystectomy? Okay. So lap cholecystectomy, perfect. So you've done a lap chole and during lap cholecystectomy, you see that there are no stones in the CBD. Okay, there are no stones in the CBD. Would you still like to explore the CBD?
Yes, sir.
Why?
So once in the lap cholecystectomy, if possible, we would, but if the confirmation is there that there are no CBD stones, then we might not.
Okay. So two things. So students are asking certain things. Number one, what they're asking is that why not a T tube? Okay. So T tube, where is it inserted? T tube is put in the CBD. I'll put in a T tube if supposing I didn't know that there were stones beforehand, but I was doing a lap chole and now suddenly I notice that the CBD is dilated and then I open up the CBD. I see there is a stone there. I remove that stone. Then I'll put in a T tube. Okay, right? Then I'm going to put in a T tube. When I'm doing an ERCP is through the duodenum. There we'll put in a stent in the CBD, a plastic stent. Okay. So here, if the CBD is not dilated when I'm doing a lap chole, I've already removed the stones by ERCP, then I don't need to explore the CBD. We can just do a cholecystectomy. That's the end of it. Okay.
Yes, sir.
Right. What do you mean by residual CBD stones?
Residual CBD stones.
Stones. Residual CBD stones are stones which can be found in the CBD within 2 years of the cholecystectomy. Okay, so those are residual CBD stones. Fine. Some students are asking what is meant by a stent. Why are we putting in a stent? We put in a stent after ERCP. Again, I said some of them put a stent, and that is if there is any stones which are left behind, they can easily come down, and they will not cause obstruction. Right? Okay, right, perfect. So I think so that was our case, and those were some of the questions related to it. I hope I hope you understood the entire scenario. Now, if you have any questions pertaining to the case, you can ask me those. Otherwise, if you have any other questions which you want to ask me, I'll be happy to answer them.
Am I
If
audible, sir?
yes, you're completely audible.
Okay.
Okay. And so you had certain questions which your users had
Yes,
asked
sir.
you. So do you want
Yes, sir.
to go over those questions which I can address?
Yes, sir. So we'll start with the questions, sir. The first question is, what are the last minute revision tips for NEET PG 21 aspirants?
Okay, just one second. Why not open cholecystectomy? Lap chole is the gold standard, right? You will only convert it to open if it's a difficult chole. If you're unable to dissect the Callet's triangle, then only you convert it into an open case, which in these days is not more than 4 to 5%. So you have to carry out a lap chole. We won't take up this patient directly for surgery because the patient CBD was dilated and ALP was raised, which is an indicator that this patient probably has CBD stones. If you know that, you first need to address the CBD stones and then do the cholecystectomy. If the CBD was not dilated in this patient, if the ALP was not raised, you could have taken up the patient directly for cholecystectomy. Residual stones are stones seen within 2 years of lap chole in the CBD. Those are residual stones. Great. Pluripotent doctor, very happy for you. Great. T-tube is inserted. If you explore the CBD, then you put in the T-tube. Okay. Yes, please.
Yes, sir. So the first question that we got, sir, what are the last minute revision tips for NEET PG 21 aspirants?
So NEET PG has been postponed. We still don't have any idea regarding the time.
Yes, sir.
So I would just say revise the high yield points, the volatile points. If you've made a 20th notebook, you should look at that 20th notebook. Keep on doing MCQs. Very important, at least 80 to 100 MCQs daily. When you're attempting clinical questions, focus on keywords. Keywords are the ones which are really going to help you in solving these long vignette-based questions.
Okay. So the next question we have is, how should the students prepare for next exam?
Okay. So those who are final year students or pre-final year students, you'll probably be appearing for the next exam. My advice to you is very simple. Whenever I know clinics are not happening these days, when the clinics start or if you have virtual clinics, please make a logbook, right? If you make a logbook, and these days, you know, cameras, you have high resolution cameras in your phone, it's extremely easy to make logbooks when you start going to the clinics, or even if you use the internet, right? So supposing this case which we just discussed, you can probably just write down briefly the history, underline the keywords, which is right hypochondrial pain, nausea, vomiting, and tenderness in the right hypochondrium. These are the keywords which you underline. Okay. Ultrasound, you've written there. Get a picture of wall echo sign from the internet. Put it somewhere. I mean, take a printout, paste it somewhere, or just copy it if you're making a logbook on the computer, and write down the management what we've discussed. Okay, so it won't take you more than 10 to 15 minutes to write down one case. And if you have all these scenarios written down of whatever you see or whatever you hear in clinical discussions, this would be a ready reckoner for all of you, especially for clinical subjects. And you can just quickly brush through it, and this will cover up majority of your surgery or medicine.
Right, correct, sir.
So that would be
So,
one. Of course, you people have a lot of time. You're not going to college these days. There are no clinics. Read standard textbooks. Don't ignore Bailey. A lot of students say that, we will read SRB or we'll read Manipal or this or that, but majority of the questions are from Bailey, so don't miss out on Bailey.
Correct, absolutely, sir. So the next question we have is how to practice clinical cases as the students are unable to go to the wards. So on the similar lines, like you just said.
Yeah, so I mean, we're discussing some of these cases online. I guess a lot of platforms are discussing cases online. So that is one source. Number two, I think so most of the colleges are having virtual classes where they're discussing cases. So follow those uh, classes as well, which your college is organizing. And once classes start again, make up for the lost time, spend more time in the clinics once they start.
Correct, sir. So the next common question that we got was tips for FMG students.
Okay. So FMG students, I would say that image-based questions are very important. Image-based clinical questions. The last FMG exam had almost 40 questions from surgery, out of which 28 to 29 had images with them. So very basic scenarios with the images is what they need to focus on.
Okay, sir. So the next common question is how should the students in third year start studying for final year subjects like surgery?
Again, I mean, my answer would have been very different had clinics been on, but these are very difficult times. So,
Yes, sir.
look, this video will be played later as well. So when clinics start, don't miss out on your clinics. Whichever case you see in the clinic, you come back and make your logbook. And as I've just told you, that logbook is going to be very important for the next exam, right? If you don't have clinics going on, then rely on virtual clinics on pages like yours where you're discussing clinical cases, and try to make a logbook out of these. Okay, read standard textbooks. Again, I'm stressing on standard textbooks. Don't miss out
Yes,
on
sir.
those. For your clinical cases, an S Das or a Makhanlal Saha, both are good books.
Okay, sir. So what are some things interns absolutely must know before they begin their surgery rotations?
Interns, when they before beginning their surgery rotations, if you made notes in surgery, read them. They will help you during your surgery postings. But most importantly, when you go as interns into the surgery ward, be proactive. You should be willing to learn. You should be willing to do procedures like Riles tube insertion, IV line insertions. Slightly more complicated procedures like chest tube insertions. All these things you people should be aware of, because these are the things which would be really life-saving, and also these are the things which are asked in the exam.
Okay,
For
sir.
students, for medical students who are starting their surgery rotation, anatomy should be very clear. So if I'm about to begin my surgery rotation, I would brush through my anatomy, the surgical anatomy bit before I start my rotations.
Okay, sir. So we have a few more questions from the live session today.
Mhm.
So one of those questions is, what is the differential diagnosis of raised ALP and leukocytosis? Can this be cholangitis?
That's what we discussed. Yes,
Yes, sir.
So if you have stones in the CBD, they can give rise to cholangitis as well. So FMG students, I know about your NMC draft. Most of the comments have been regarding that. I totally support you guys. I've been supporting you guys on Twitter as well. And let's hope your voice is heard, and they'd make the necessary changes.
Yes, correct, sir.
Yeah.
So, sir, up till now, those are the only questions. The rest, sir, you have answered them already, sir, through the live chat.
Perfect. All right. Any other
Yes, sir.
questions? Thank you all for joining in. It was great interacting with all of you.
Thank
Any
you,
other?
sir.
Thank you very much. Thank you for having me over. Any other questions? Let's just wait for a minute.
Yes, sir.
Otherwise, Your first year, I guess, focus on the first year subjects first, but as soon as your clinics start, Ayush, you should start making a logbook. Okay, perfect.
Yes.
I thank you very much. Let's, if everyone like this session, let's see if we can do more in the future as well. Okay.
Thank you, sir.
T-tube, I've again told you, T-tube and stents are different. T-tube, I mean, after ERCP, you put in a stent in the CBD. That is different. T-tube is that if I am doing a lap chole and inadvertently I find out that there is a stone in the CBD, then I open up the CBD, explore the CBD, then I put in a T-tube. Okay. For trichobezoar, CECT will be able to clinch the diagnosis. This session will be saved, I think, so they will save the session,
Yes, sir,
and
we
they'll
will.
probably post it. So you can have a
Yes,
look
sir.
at it later as well. All right, thank you very much.
Okay. Thank
What
you, sir.
about elective surgeries in COVID patients? So these days we are facing a huge crunch in Delhi. So, you know, we are prioritizing our cases. I am only operating on malignant patients now, only doing cancer surgeries because, you know, those are semi-emergencies. We can't ignore them. But all the benign procedures, the scarless breast surgeries, which I do, all those things have been put on hold and we'll do them later. So everyone is prioritizing. There's shortage of oxygen here. So tough times for everyone.
Yes, indeed, sir.
Yeah. All right. Thank you very much. Good night, everyone.
Thank you,
Stay
sir.
safe and all the best for the exams.
Thank you, sir. Take care,
All
sir.
right. Bye. Bye.
Bye.